So we're gonna start to do a very important topic for today. It's gonna be FAP. If you're going for your Q1, this is one of the most important topics which you need to know it nicely for your exam. It's highly tested and you need to be aware how to study it, how you're gonna approach this topic to prepare yourself for Q1. Yes, you can waste your time, you can just repeat it, you can keep reading it, yes. But if you don't think and know how the examiner is going to test you on this point, how the examiner is going to ask you about this topic, which questions is very commonly asked in this topic, you will never ever get a good mark or even have a good luck in this exam. Yes? We did speak before how you're going to apply the information or how you're going to understand the examiner mind. Yes? Today we're gonna apply it on this topic now and few other important topics from your general surgery. What I need from you, you need to get your notes under your hands. If you are only watching this video without taking notes, you are wasting your time. Please go and get notes. If you are writing in your iPad, that's okay. On your phone, it's okay. Just take notes. Yes? We're gonna have questions. We're gonna have few activities through the videos. So please try to concentrate now. I'll ask you after you are done with this video to type down on the box or the chat box or maybe send me your notes. Please do not waste your time. Let's start. Let's start with FAP. Very important. What you need to know about it for your exam. That's what you need to concentrate on right now. First, it's 1% of the colorectal cancers, which is affecting males and females. Very important. The second question, which they love to ask about, if they are not asking you about this, they're going to come down to ask you the next. Please have your notes. I'm going to ask you to send me your notes. They're gonna give you a history, they're gonna give you a presentation, they're gonna give you maybe it's a FAP, and they're gonna ask you about is it autosomal recessive or dominant? Yes? Your answer is gonna be here. Autosomal dominant. And this point, I'm gonna remind you later that it's very important for your exam. And we're gonna study it more. We're gonna go around it. We're gonna see the questions, how it's coming from this point. Yes. So we're gonna study it nicely. The second thing which they ask about in this point, which gene is gonna be affected? You're gonna find it in ACE. You're gonna find it in Canada Q Bank. Easy. APC gene. So while you are taking your notes, you need to have a nice table like this in your notes. One side, it's going to be your autosomal dominant. The other side is going to be autosomal recessive. Under this table, which you're going to have it in your notes, you're going to come down and write FAP. Yes? Any other condition we face while we are moving, you come to add it to your lovely table. Recessive, you come down to add it. More dominant, you come down to add it. Yes? After 2 to 3 months studying with us, You're gonna have a full table which you will need it for your final revision before you go for your exam. So let's see where we did stop. Usually there is two things which is confusing everyone here or for everyone here. First thing is fab itself. Fab itself, it's gonna be hundreds to thousands, big amount. If they are telling you the number is less than 100, you call it attenuated fab. What you gonna call it, guys? Please repeat. Attenuated fab. What is attenuated fab? Is it different from the regular fab? Yes, or it's the same thing? Usually, because everywhere you're gonna move down, they are writing about it. Do you see here? Attenuated fab, it's a mild or a milder variant of the fab itself. Yes, definitely it's happening because of which gene, guys? Please wake up. APC. The number is less than 100, so it's fewer, yes, or few of them. And we're gonna speak about it nicely now. Yes. So let me clear here. Next point. So please write down the answer. If they are giving you a mid-age patient who is presenting to you with a dozens of adenomas, is it gonna be FAP or attenuated FAP? What do you think, guys? They wrote for you only dozens. Dozens, we are not speaking about hundreds or thousands. We're speaking about less. So, most probably it's going to be attenuated fat. And this hint was the only one to give you the answer in one of the A's questions. Yes? So, you need to be awake. Please write everything we are speaking about in your notes. I'm gonna ask you to send this notes to my number after you are done with it. Yes? Do not waste your time. Next point. If they are asking you which one of fab and attenuated fab has a higher risk for colorectal cancer, what do you think, guys? Do you think the one which got hundreds to thousands or the one which got less than hundreds? So, what is your answer? Please. The one which got 100 to thousands or more. Definitely the attenuated fab is still in risk, but it's less. If you go to this line which is written for you or which in your TN here, TN wrote for you 100% lifetime risk of colon cancer due the number of the polyps. It's gonna decrease to be 70% in attenuated fab. Very important. They like to test such points in between the lines. Yes? So If they are giving you a FAB or adenomatous polyps, which is happening predominantly in the right side, what you gonna think about if they are not mentioning for you something about the numbers? Is it gonna be FAB or AFAB? What do you think? The answer is gonna be attenuated FAB. And this is very important for your exam. The next point which I wanted to speak with you about under FAB. So much questions, guys. I'm trying to cover for you everything. You need to have your notes. After the session, you need to send for me your notes. How you gonna find the patient or how the patient with FAP is gonna present to you? First of all, you're gonna find a numerous colorectal polyps. Please write down. Do not waste your life joining a random videos or joining random sessions without you make it worth. Write down because I'm going to ask you to repeat. I'm going to be asking you to recall information by the end of this video. Yes? If you will be able to answer the questions, this means that you did not waste your time. If you are not, unfortunately, this means that you did waste your time as usual. You need to do something different. First of all, the first information which you need to remember here is you're going to find a numerous colorectal polyps, but it's usually asymptomatic. Unless it's complicated. How it's going to be complicated? Either you're going to get bleeding or you're going to find bleeding, or you're going to find the patient with anemia, or maybe he or she already got cancer. The next, extraclonic manifestation, which is written here for you. Extraclonic manifestation is very important. Why it's important? Because you are thinking here not only about the colon, but it did involve for you other places as well. Under the extraclonic manifestation, you need to write the next. You need to remember 4 points. One, please write it down. I'm going to ask you to send me your notes. It's going to be upper GI. What you're going to see or what's going to be affected in the upper GI? Either you're going to look for the duodenum or you're going to look maybe for the stomach or maybe any part of the upper GI. Stomach and duodenum is the highly tested points. Next. Thyroid That's number two, which you're gonna have in your notes. Thyroid. You might find a benign multinodular goiter, which is gonna increase for you the risk for thyroid cancer. Next, number three. Number three is gonna be your pancreas. It could be your pancreas, it could be the bile duct, yes, it could be the adrenal, so anything out of it. Number four, which you need to have it in your notes. Number four is CHRPE. What do you think it is? CHRPE. It's congenital hypertrophy of the retinal pigment epithelium. And it's written for you down here. You need to remember how or different ways how they can write for you the same thing because sometimes they are testing you about it. Yes? And it's very important. The congenital hypertrophy of the retinal epithelium pigment is very important because it's happening early in life. So you need to remember it. It's highly tested point. Next, I need you to concentrate. I need you to think about the next point. First question. You have a 19. Please concentrate. I'm going to ask you to repeat now. Please start to take notes while we are reading the question so you're going to remember it nicely. So, for example, we are saying 19-year-old, so you're going to write maybe mid-age man or keep it in your head. Family history, you're going to keep in your head family history about this. Please start to apply this. I'm going to read and you try to keep the information in your head. A 19-year-old man with a family history of a colon cancer. Do you think it's something good or bad, guys? Is found to have hundreds of adenomatous polyps on colonoscopy. So, man, history colon cancer, you found hundreds. Hundreds. Is it FAB or AFAB? On examination, he has a hard, painless bony swelling along the mandible and multiple epidermoid cysts on his back. So he's coming to you with a bony swelling, which is happening on the mandible, this 19-year-old, and multiple epidermoid cysts on his back. Which associated lesion is he at high risk of developing? This is a very commonly asked question. Very important. So it's a 19-year-old, history of colon cancer, hundreds polyps. You're thinking about FAB, you are moving down. You find he has a hard, painless, bony swelling, yes, along the mandible and the epidermoid cysts around or on his back, sorry. Which associated lesion is he at high risk of developing? If you didn't read your book nicely, if you didn't read between the lines, you won't be able to answer this question. Or maybe you could guess it or you exclude the options. But the best way is to read your book nicely. That's what we are trying to do every session, to go through the book nicely. Gardner's syndrome. You're gonna find FAP plus extra intestinal lesion. Yes. So the road for you here, osteomas or cysts. Do you remember what we just did in our question? The last thing which they are asking you about, which they are asking you about, what is the highest risk or the highest association is gonna be here? If they mentioned for you FAP and they are trying to get you under the Gardner's syndrome, the last option for you it's gonna be desmoid tumor. Did you see how the answers and the questions is coming between the lines? Did you see how important that you need to understand that you are not wasting your time just to go through TN with any regular way or just blindly read it, but you need to be conscious while you are reading it. Very important. The second question. The second question, which is coming to you here, is a 12-year-old boy has, please concentrate and start to take notes. If I ask you to repeat the question which we just finished, do you think you need to go through it again or you remember it? Please tell me if you still remember it or you did forget about it. If you were conscious while we are reading it and you did follow all what we are saying, you will be able easily to recall it, even without looking at it. Next, try to do this. If you did miss the previous question, try to not miss this one. A 12-year-old boy has chronic diarrhea and iron deficiency anemia. Colonoscopy shows a numerous adenomatous polyps. 12 years old, chronic diarrhea, iron deficiency anemia. Colonoscopy shows a numerous adenomatous polyps. He now presents with morning headaches and vomiting. His neuro exam shows ataxia. Which CNS tumor is the most classically associated with his condition? You are stuck again. Exclusion you're gonna do here? Are you gonna repeat reading the question again? We did read it, yes, nicely. 12-year-old, yes. And he's coming with a chronic diarrhea, iron deficiency, anemia. So you keep this in your head. Next, colonoscope is showing you a numerous adenomatous polyps. Next, he now presents with a morning headaches and vomiting. Something new is happening here. You found ataxia. Something is happening with this fab. If you didn't read in your book between the lines, you will miss this question. Or maybe you did hear about it, maybe you did just exclude the options, but 100% you will find the correct answer If you did read your TN nicely, let's go back. They wrote here for you about Turcot syndrome, FAB plus CNS tumor. They are asking you which one. If you didn't read this line nicely, you might confuse it. The answer is written between your hands in your book. Childhood cerebral medulloblastoma. Two important syndromes. Questions is coming on it. You need to know it nicely. Next point. Next point is exam favorite. You need to know it nicely. It's one of the most highly tested and high yield points, specifically in this chapter. So try to recall with me, guys. We did say fab and attenuated fab. Fab, what is the difference between both of them? One is happening or the numbers is numerous, so hundreds or thousands. The other one is less than 100. Fab is having a higher risk for colorectal cancer, 100%. AFAB is having 70%. Yes, very important. Both of them, the most common point. Which gene you're gonna find it affected? It's APC gene. And if you are speaking about APC gene, do you think it is autosomal dominant or recessive? I think by now you know the answer. When you're gonna do or refer your patient for APC gene, this is the most important point which you need to understand here. Please concentrate because I'm gonna ask you questions by the end of this video. Yes? If you are not able to answer it, this means that you did waste your time here. Please concentrate now. APC gene. First of all, if you have a patient who's present to you with more than 100 or 100 colorectal adenomas, your answer is referred to APC genetic test. Someone is going to jump in as usual and ask, how did I find out that there is 100 colorectal adenomas? Maybe symptoms started. Yes. Maybe it was a screening for you. Maybe you were checking about something else. Whatever is the reason, you have found out it's more than 100 colorectal adenomas. You're going to go ahead and do it. The next point, please concentrate. You need to have it in your notes because it's very highly tested point. So first one is more than 100. The second point, which you need to remember here is, if you have a high risk first degree relatives, the second point is first degree relatives. When you gonna start to check about it? First degree relatives. Yes, you might have young, you might have old, you might have whatever the age. Usually, anyone is more or 10 years old, you can go ahead and check about them. Yes. So next, that's the last point. If you found someone who's presenting to you with attenuated FAP, yes, we said it's less than 100. Will you test them or you will let them go? They still have, remember, a 70% chances to get colon cancer. Your answer here is we can refer them or we need to refer them to the screening APC. Yes. So here you're going to confirm the diagnosis number three. If it's more than 100, you're going to confirm the diagnosis by doing the gene test. If you are looking for the first degree, it's your perisymptomatic testing. So you need to know the reason why we are doing the ABC gene for each one. Did you remember the criteria, guys? Do you think, can you repeat the 3 points now? So you have, please concentrate. You have 2 points here. First one is, or first two, or the 2 points which you need to remember is diagnostic or to confirm the diagnosis. To confirm the diagnosis, you have two things. Either it's FAP, either you are thinking about attenuated FAP. FAP, if you find more than 100 polyps, you're going to do your ABC gene. AFAP, if it's less than 100, you're still going to do it. To confirm your AFAP. And the last point is to provide the pre-symptomatic testing if it's a first degree high risk patient. Next. The next question which they are asking about this test, is it sensitive and specific or no? Definitely yes, very much. Specificity is more than sensitivity. They wrote it for you down here. Please remember they love to ask about it. Next. Next. So you need to remember the 10 years old. Do not forget about this. Now, if you have a patient at risk, first degree maybe, or whatever it is, but you find no polyposis yet, what is the best next step for you? They love to ask this question. You're gonna do annual flexible sigmoidoscopy. Please concentrate, it's sigmoidoscopy here. When you're gonna start? From puberty to age 50. Very important for you. You cannot go to your exam if you don't know this point. To age 50, what is going to happen after this? Because the question which is coming to you here, it's a patient coming to you, it's a high risk, it's first degree relative. Maybe you did your genetic testing. Usually, usually, if you find patient with a high risk before you do genetic testing, Sigmoidoscopy is your answer. If you do your genetic testing and you find the patient got the APC gene, or he's presenting to you with a polyposis, your answer it's gonna be annual colonoscopy. You're gonna check about the whole colon. Starting at age 10 to 12. Again, I'm going to repeat this point. You need to concentrate because you need to have it in your notes. I'm going to ask you to send me your notes. If you have a patient at risk, but there is no polyposis yet, you're going to do here annual flexible sigmoidoscopy. What age you going to start to do it? Puberty. Till what age you going to stop to do it? It's going to be 50. After 50, what you going to do for this patient? Will you send him home? Will you ask him to not come again? Or what you going to do? After 50 years, you're going to just return to the regular screening procedure. The same guidelines as any other patient. This in case if you found no polyposis. If you found polyposis or this point, or the APC gene mutation, you're gonna go ahead and do colonoscopy, not sigmoidoscopy here. Starting from age 10 to 12. Very important. Once you find the gene, there is few questions is coming to you on this point. Wake up, please, and have it in your notes. First point, when will you consider this child as a surgical candidate? When you're going to take them to surgery? Because you are starting to screen them with the colonoscopy 10 to 12. Will you do for them surgery right away? Definitely no. Your answer is written for you in your TN. You're going to do the surgery 17 to 20 years. Very important. Yes. Next point. Once you do your or you are checking about the patient, you found your polyposis and you found the APC gene mutation. And you're gonna screen annually with the colonoscopy. Is it all what you're gonna do? What do you think? They come to you here and they ask you more. What you gonna check about? And while you are sitting and facing such question, you're gonna ask yourself, okay, they did the APC gene, they did the colonoscopy already. What I'm gonna do here? Your answer needs to be upper GI evaluation. Yes, and they wrote it for you here. Upper GI evaluation. Do you remember, guys, the extraclonic manifestation which we spoke about? Can you recall the 4 points which we spoke about? Try to squeeze your head. 4 points we spoke about it. Can you recall it? First one, starting with the U, it's upper GI. Second one, it was T, thyroid. Third one, it was P, pancreas. Fourth one, it was CHRPE. That's your congenital hypertrophy retinal pigment epithelium. What is the two syndromes which we spoke about? The one with the osteomas, epidermoid cysts, and the desmoid tumors. Can you recall the name, guys? Can you recall the name? Gardeners. If they are giving you FAB plus CNS tumor, which tumor are you going to think about? Starting with the M, medulloblastoma. Yes, and what is the name of the syndrome? Torcott. Yes. So we spoke about the APC gene. We spoke when you're gonna do it, what you're gonna do with it, how you're gonna do it, for who you're gonna do surgery, how you're gonna do it. Usually the surgery or the prophylactic surgery for you, which is written for you down here, it is required or you can do it from 17 to 20. The next point which they wrote for you here, it's optional. What you gonna do? What is your options here? It's either you're gonna do the total proctocolectomy or you're gonna do the ileostomy. Or you could do the total colectomy. And plus, you could do the ileorectal anastomosis. If they are giving you the same vignette as the one which we got with the Gardner's syndrome, and they are asking you about the desmoid tumor, what is the treatment or what is the management? Very important. I'll leave you to look for this information and message me about the right answer. Then I'm going to confirm it to you. The last point, which I'm going to end for you, fab with it, is very important. This question. At 28, please concentrate. This question is very, very, very high yield. A 28-year-old woman is diagnosed with a FAP. After genetic testing confirms, or the genetic test is confirming for you the APC, you explain that first degree relatives have a 50% risk. Why 50% risk? Is it autosomal dominant or recessive? I think that you know the answer by now. That the early surveillance can prevent colorectal cancer. She becomes upset, says, "Don't tell my parents or siblings. I don't want them to know anything about this." This is an ethical dilemma. Why? Because now you have a first degree relatives who could be in a very, very high risk for CRC. If you have patient with FAP, your chances to get CRC or colorectal cancer, it's going to be 100%. Even if the patient or the relatives, they got a FAP, attenuated FAP, they have a 70%. What will you do in this condition? Will you consider this as a risk to harm? Will you consider this as it's her right? Will you let the others in high risk to have cancer while you know about this? Yes? And this is your homework question. If you are wishing to know the answer, you can message me. Yes? Try to find it out. Reach me out. I'll be so happy to see you finding the answer for this question. So, we're gonna revise what we just did for FAB, but before we revise what we did now for FAB, we're gonna go ahead and study a very important topic here. The most important topic which you're gonna deal with after FAB related to the colorectal cancer, it's gonna be HNPCC, hereditary non-polyposis, and I need you to remember and put under non-polyposis 3-4 lines. Hereditary non-polyposis colorectal cancer, or my favorite, Lynch syndrome. Please have your notes ready to go through what we're gonna do right now. I'm gonna ask you to repeat it. So, first thing you need to remember, if they ask you about what is the most common inherited colorectal cancer, your answer is gonna be Lynch. Very important. If they're asking you about which colorectal cancer is affecting both genders equally, males and females, and it's 1%, your answer is gonna be FAB. Next. Next point, it's gonna be Lynch story. Please write it down. Try to memorize it. You will need it for your exam. First, Lynch, he is a good boy. Please concentrate. I'm gonna ask you to repeat it. Lynch is a good boy. Lynch is a good boy, and his father is. So, Lynch is a good boy. He is 18 years old. His father is 44 years old. And he was diagnosed with Lynch syndrome. Or with other words, he was diagnosed with HNPCC. Very nice till now. This good boy Lynch, he grew up and he found his father was suffering. He started to question his dad. What do you think he started to question his dad about? What do you think, guys? Please. What do you think 18 years old he's gonna question his father about? So early morning while they are having their breakfast, before we go for the story, which breakfast do you think that they are getting? I will leave for you this question. Definitely, you know which breakfast they are getting. While they are having the breakfast in the morning, the father is telling his son, my son, this is the father speaking, my brother, so it's the uncle, and my dad, it's the grandfather. They also got HNPCC. So the father told him, I'm worrying about you. I wish you, Lynch, to go ahead and make sure that everything is okay with you. I need you to travel. Where do you think the kind father is going to ask this good boy Lynch to travel? What do you think, guys? Tell me your ideas. What do you think? The father was kind enough to ask the good boy Lynch to take himself and travel to Amsterdam. The father told him that there is a very good physician I know from there. You need to go and visit him. What do you think that Lynch did ask his father? Lynch was hungry. He did ask his father, Dad, do you think I'll be able to find my favorite dish there? Hungry guy. Morning, he's thinking about food. He's traveling, thinking more about food. Yes? Write me down in your notes or down. What do you think? Which dish Lynch is looking for? I think that anyone joining our group, you know the answer. So Lynch, he took himself and he did travel to Amsterdam. He did reach to the physician. What do you think the physician is going to tell Lynch, guys? I need you to stop the video here or to squeeze your head. What do you think the physician is going to tell Lynch? What do you think the physician, with Lynch coming to him, three or more relatives with a confirmed Lynch? One first degree relative, two or more generations, the father and the grandfather, one diagnosed before 50, which is the father. And definitely the name of it, we are saying HNPCC. We're speaking about non-polyposis. So no fab or fab is excluded for you. What do you think you're going to do in this condition? The physician now, he got Amsterdam criteria 321. You need to remember it nicely. If you don't remember the criteria, you remember the Lynch story. Yes, it's going to make it easy for you. What do you think the physician is going to do for him now? If your answer is genetic testing, which is here, could be right answer. If you say I'm going to do for him colonoscopy or sigmoidoscopy in this condition, your answer is not accurate. Colonoscopy starting at age 20. How old is Lynch? 18. so you cannot screen him or do for him colonoscopy. But genetic, maybe you could do it. How often you gonna screen him when he reaches age 20? What do you think, guys? You gonna do it annually. Lynch syndrome, is it autosomal dominant or recessive? What do you think? It's autosomal dominant. Which side is more affected? Usually, it's the right colon. Is it more in males or females? More in males. Age 45. If they are saying for you type 1 and type 2, type 1, it's mainly colon cancer, which you're gonna suspect it on the specific side. So if it's on the right side, you're gonna suspect it there. Type 2, colon cancer with extraclonic manifestations. Ovarian, liver, a small bowel, adrenal, whatever it is. That's type 1 and type 2. Yes? Any patient is fulfilling the criteria and you're thinking about Lynch, you need to investigate them nicely. Genetic testing, and once they reach to age 20, what you gonna do? Colonoscopy. If you confirm the diagnosis and you find it, what you gonna do? Treatment, surgery. Is it common in male or females? Males. If you're speaking about FAP, is it common on males or females? Equal in both the genders. If they are giving you only colon cancer, it's type 1. If they give you colon cancer plus extra colonic manifestations or tumors, that's going to be type 2. Amsterdam criteria, it's Lynch, 18 years old. His father got diagnosed at 45 years old with a Lynch. His uncle, grandfather, they got it as well too, yes. He got no FAPs. You're going to do for him genetic testing. Very important point, which they love to question you here about it, is the next. They love it. It's mentioned in your book more than 7 times. What the information is saying here, or this note, which you need to have it down. Iron deficiency anemia in elderly. What you gonna do? What is the best next step they ask you? That's why people they face the questions and they come back to say for you. Or, oh, I didn't have enough information in my questions. I couldn't answer this question maybe. But it's a clear line in your book, mentioned more than 7 times. Iron deficiency anemia plus elderly ABC for you. You're gonna go ahead and do colonoscopy. It's mentioned in surgery, emergency, family medicine, so many chapters. Even hematology, it's mentioned. If you have the same information, it's mentioned for you many times. This is increasing the chances that you get it in your exam. Yes? So let's recap whatever we have done till now. Everything. Please concentrate. We're gonna recap everything. Which is it autosomal dominant or recessive? Both of them, Lynch and Fab, both of them dominant. If you are thinking about Fab, if they are telling you hundreds to thousands, which one it is? It is Fab. If they are telling you less than 100, it is a Fab. If they are telling you that extra clonic manifestations with Fab, what it is? We had four things. Can you recall it? Upper GI, thyroid, pancreas, CHRP. If they're asking you about which syndrome it's going to be if you find Fab plus osteomas or epidermoid cyst plus maybe desmoid tumors, which syndrome starting with a G? I think you remember it. If you find Fab plus CNS tumor, medulloblastoma in a child, what are you going to think about? Which syndrome it is? The first line investigation for you, it's going to be genetic testing in three conditions. When you're going to refer the patient for genetic, we say two to the diagnose. To diagnose FAB and AFAB. And the last one is to check about the high risk patients. And do not forget to search about the question which I told you about it. When you're going to do sigmoidoscopy, when you're going to do colonoscopy, I think that you know it. When you're going to repeat or how regularly you're going to repeat each one of them, I think you know it. When you're going to do surgery for patient with FAB, what age it is? If you have a patient with polyposis and FAB or your gene, APC gene, is positive, you do colonoscopy annually, yes? Plus, what else if they did colonoscopy already? I told you about one extra investigation. Lynch, I think you remember it nicely. If you did reach till the end of this point, please, I'm waiting you to send me your notes. Please study good and let me know if you need any more help while you are studying for QE1. Hopefully it was useful for all of you guys. Hopefully you're going to study this topic and you're going to start to study TN and approach it differently after our way to study the book. Thank you so much.